Welcome to the PTR Physiotherapy Rehab Podcast. My name is Warwick Schmidt, and in this podcast we interview subject matter experts, authors and elite athletes to help inform clinicians and patients and generate discussions around sports, rehab, health and how to get people back to their best. We hope you can take away some content and use it in your practice. Okay. Welcome to the PTR Physiotherapy Rehab Podcast. Today we have two guests on to talk about radicular low back pain. Steph and Rob. One's a patient and one's a low back specialist, so I'll ask them to introduce themselves. And then Rob really kindly has come on as a patient to talk about his experience and see whether it ties with the evidence, and then hopefully at the end tie in Steph's extensive experience with low back pain for advice for clinicians who are facing these often difficult cases. So if I could ask Rob to introduce yourself.
Yeah, so my name's Rob. I'm 32 and I had lower back surgery when I was 31.
Can you talk us through why you had the back surgery?
So early on in 2023, I started getting lower back pain and some sciatic nerve pain in my right leg. And over the course of about 6 to 7 months, that progressively got worse and worse to the point where it was more or less intolerable. And on doctor's advice, I went forth and had back surgery. And it worked out quite well for me.
Can you talk us through the initial experience? Because you mentioned when we first just introduced ourselves that it didn't necessarily come on really, really quickly.
Yeah, so it started off as I've had little lower back niggles from time to time, when I was younger, all through my late sort of 20s as such. But this one was a bit different. I think I was in the process of getting back into running. I was trying to get into a bit of a fitness regime, and all of a sudden I started feeling sort of quite tight and quite sore in my hamstring. And it's so much so that I thought I'd actually pulled a muscle or done something like that. So I didn't even think it was back pain to begin with.
So it didn't feel like, it may have felt like a muscle strain.
No, it was sharp, and it was only when you sort of like stretched it as such. So started seeing a physio, and they diagnosed it as quite quickly as being sciatica caused by a problem with the lower back.
Do you think that assessment was efficient? I mean, you mentioned it was the first one, and they identified that quite quickly.
Yeah, it was. I mean, when I went in there, I was thinking, it's going to be a sprain or something like that. They're going to say, rest it, whatever. But it didn't take him long to pick up that. Yeah, it was sciatica, and he was spot on about what it was in the end.
And at that point, did you have any pain beyond your knee? Was it just?
No, it was just literally in the hamstring. Yep.
Do you remember, just out of interest, any specific tests that you felt, wow, that made you realise this was a nerve injury from a patient's point of view? Yeah.
It was when he was going through sort of, if you stretch your leg this way, stretch your leg that way, you can feel it here, where you can't feel it there. If it was a muscle injury, you'd be feeling it here when you put sort of pressure on the muscle, but because you're stretching it and that's where you're feeling it, that's pulling it. But what I was impressed about is very sort of early doors, I was given sort of basic physio exercises to like floss the nerve to try and alleviate some of the pain. And initially that actually did sort of help, kept it going, but it never went away. It was always there as such.
Steph, flossing, gliding? Is that something you prescribe? That could be a whole podcast on its own, let's be honest.
Yeah, I do. I use it. It depends how early on you want to be doing it as to how irritable something is. So if somebody's got a really irritable nerve and you add that, you potentially flare it up. So if it's more so from a point of view of things are resolving or post-op, once it's settled initially post-op, it's a great way to get that mobility back. But prior to that, I'm always, and I will literally say to the patients, this is to move it, get it flexible, but if it aggravates anything, you back off. So you just don't want to irritate it.
The name of the game is just settling it down. Do you have any sort of tips or tricks for these very acute early phase patients? Something you would do, not necessarily a glide, but something similar that might kind of prepare them?
I suppose it really depends on exactly how they present. The most important thing is just for them to be able to find positions that make it more comfortable. So I don't know whether there was a particular position you got into that was much better, because some of them, they've got a really big disc, actually quite like being in flexion, and everyone's always like, no, that can't be right, because when you flex, that puts more pressure on the disc. But actually some of them, if the disc is big enough, actually they like to be in flexion because they give the back more space at the posterior element, if that makes sense.
You decide on clinically as the patient, so it's not
most of them like to be either upright or flat or lying down with their legs up in sort of on the seat of a chair, so that they're just taking all the pressure out of their back.
Lying on the floor or hard surfaces or something sometimes.
Yeah, sometimes they do, sometimes they don't. I mean, I've had patients that say, I put a board under the back of my back, or I lie on the floor, and I'm like, well, is that comfortable? They go, no, it's really uncomfortable. I'm like, well, don't do it. So it's very much about whatever they find is the easing factor, rather than there being a specific. I don't know whether there was a particular movement or position that you were best in before you had your surgery that made you more comfy.
Yeah, I think it was more like that, lying down with the legs bent. I think when I had my legs straight, it would start to get inflamed. Also sitting down. So when I was driving, I remember I'd set off, and then by the time I got somewhere, that's when it sort of flared up, and I was feeling really stiff afterwards as well. But it was sort of that natural sort of curved sort of body position was what was the most relieving for me. Yeah.
And so you mentioned you initially didn't start out with that raging pain. It wasn't 10 out of 10 life-changing stuff. But so how long would you say you had that kind of gliding assessment with the initial assessment with the patient, before things escalated? It
sort of, I would say in the first month, it would have been a 4, like sort of 4 on the pain. It was tolerable, but it was consistent. It never went away. It didn't matter what I did, what medication I was prescribed in terms of naproxen or at the time it was naproxen and paracetamol. Later on, as it started to get worse, there was cocodamol. But it sort of took the edge off a little bit, but never went away. And that was the thing I think that started to, that I started to become aware of, is this pain was always there. It was not, it wasn't something that you could soothe, put an ice pack on. It was there 24/7 as such.
Unrestricted in terms of doing, you said you're into sailing and all of the activities. That didn't impact it just then?
So shortly after I started going to the physio, I stopped running, and I was doing rock climbing and other stuff like that. I stopped doing a lot of that. The sailing I had stopped, so I stopped doing some of the training sessions with the crew. But as the date in July for the Fastnet race was approaching, I had to do qualifying races and stuff like that. So it was a case of, right, can I push it a little bit to see if I can go it? So I did one sailing race, and it was actually perfectly fine. I got off the boat feeling better than I'd gotten on the boat, which was sort of good. So it was this sort of case of sort of like trying to build up sort of my ability with the pain to be able to do the race. But like I said before, it sort of gradually got a bit worse and worse. And then on the actual race itself, so when we were doing the fast nap, that's when it really got bad.
Can you talk us through, do you remember when it went? Is it one or?
Yeah, so to give a bit of backstory on the race was in very heavy conditions. It was very windy. There was a lot of pressure on the boat and stuff like that. So we started the race and we set off and everything was fine. We got out past sort of Poole and Weymouth, and we're sort of battling with a lot of waves, a lot of wind and whatnot. And I was on the winch, and it wasn't like there was a split sort of like I've tweaked it or anything like that. It was just, there was this sort of like slight niggle, which I hadn't necessarily felt before, but something was a bit different. And sort of, okay. And then it sort of gradually built worse and worse and worse. I went down, lied down. I was like, right, I've got to my back's playing up, I've got to lie down a bit. And as I was lying down, this pain just started getting worse and worse and worse. I was taking, I had my cocodamol, my naproxen, I was taking all of it as such, and and trying to sleep it off. And it was literally like my leg was on fire, pins and needles. It was tingling, and it felt like something was very seriously wrong. And
at that point, was it still just in the back of your thigh, or had it gone further down your leg?
so at this point, it was my whole thigh was tingling, and sort of I was starting to get a numb feeling in the sort of around the feet as well. So the skipper then decided that because of that we'd retire from the race and would return to shore. So we came back into Leamington, and when I was picked up at Leamington and taken into Southampton General.
Went straight in. Was that who made that decision that you went straight in? Was that you decided
So on the way back into, as we were sailing back, returning to shore, we spoke. So we called 111. Was speaking to them on the phone, and the person there just said, "Get yourself into hospital," because it had reached that threshold of, although it hadn't sort of gone into the emergency state where sort of you're losing bowel control and stuff like that. He said, if that happens, you need to call an ambulance and get in quickly. But because of the pins and needles and the me starting to lose sensation in the legs, that's when he said you need to go into hospital as such.
And that kind of matches with the stats. I mean, some of the evidence shows that 63 to 72% of radicular patients experience the paresthesia, so the numbness. 35 will experience radiating pain into the lower limb, so kind of matching what you've got. Almost a third, 27, will experience the numbness, and then muscle weakness is present in sort of nearly 40%, and affecting the reflexes. And I'm guessing that's what they had a look at when you got to the hospital. Is that right?
Yeah. So I went into hospital. I was assessed by one of the doctors there. They weren't concerned in terms of that it was serious or that there was any, when I say serious, it was obviously that I was in a serious amount of pain, but it wasn't going to cause, that I hadn't broken my back or something like that. So it was a case for them about me managing the pain. So they had, when I got in, they had given me a bunch of morphine, which it helped, but it also basically knocked me out. So I was very, very dopey as such. But then they started me on the anti-neurotics. So that's when they started giving me the amitriptyline to start targeting the specific nerve pain. Yeah.
And Steph, that used to be, from my experience, not that it's too thorough, but the amitriptyline was sort of acute early on nerve pain. Is that in your experience? Is that something, or has that changed?
No, so they use it very much for those so any of the tricyclics can be used to help with that nerve pain, because it blocks you being able to feel the pain, the nerve-based pain. And it can be really effective. It's not normally first line of what they will give. So they'll try the non-steroidal anti-inflammatories, they'll try all the lowered, and then they'll up it, and then you go on to your codeine-based stuff. And then if that's still not helping, they sometimes use tramadol, which again is quite useful for nerve pain. And then the amitriptylines that can be helpful as well. They're useful quite often. People will say, actually, it's from what the patients say to me, is that nighttime pain is a big issue, especially nerve-based. And so that seems to help with the sleep side of stuff if they're struggling.
And is that kind of how you experienced as well? The night getting to sleep was rough?
Yeah, especially so after I was discharged from hospital, I was off work for 2 weeks, basically recovering from that spell. And that was also starting to get used to the amitriptyline, because it wasn't something that worked straight away. It took a bit of time to build up in the system and basically also kick in. When it did kick in, it probably helped. It was probably the thing that worked the most for the pain. But as it also was a antidepressant, it also really messed up sort of like my psyche and sort of my ability to function. So I got a lot of like brain fog. I was a lot slower for working and just sort of my ability to sort of like perform tasks as such. So it did take a big sort of hit so it had a sort of counter effect for other day-to-day activities as well.
And I guess, Steph, with those sort of the situations like this, you just kind of reassure patients and just try and keep them ticking over until the pain's resolved.
It's not a drug that's taken lightly by any means, and it does definitely have that feeling of people feel really groggy on it. You only get given small doses from a nerve pain release as opposed to having bigger doses for the antidepressive type if you're taking it purely but for other reasons. But the issue, so some people will be given it just for nighttime pain, and so you take it and it's for that just the evening and into the night. But again, the patients that take it, if they take it late in the evening, they feel really groggy until about 12 hours after, because it's a slow release type effect. So again, for the advice for patients, it's if you're going to take it, you want to sort of think about taking it 12 hours before you want to be awake and up. Because if you take it at 10 o'clock at night thinking this is for my nighttime painkillers, you are still a little bit groggy at 7, 8 in the morning. Whereas if you take it at 7 at night, then by 7 in the morning you're feeling. So it's just that trying to manage that as well can be quite useful for patients to just not feel, because otherwise they will tolerate it for a couple of days. And I bet you probably got to a point where you're like, actually, I don't know whether I'd rather have the pain or rather be feeling groggy and shocking. And it's that trying to balance that so that you can use the medication as well as not feel too unpleasant with it.
And that's what they sort of did with me with the doctors. So they gave me 10 milligram tablets and said you can take up to 3 of these, and you want to fluctuate, you can halve the tablets, but you want to try and be on as little as possible so that you can function, but as much as that you don't have pain that's stopping you from doing day-to-day activities. So, and as you say, it was something that would take at night. And what was interesting is that I'd probably take it a couple of hours before I was going to bed, because as soon as I took it, I got very dopey. And basically, so if I took it too early, I wouldn't be able to function for the rest of the evening. So I take it and just before bed, and I would be fine probably with pain up until the early afternoon, and then it would always be the early afternoon that I would have to rest up and sort of try and deal with a little bit of pain. And it was that sort of 3 to 4 hour period between sort of afternoon to sort of like late afternoon, early evening before I was going to bed that I was sort of the worst part of the day as such for pain.
So if we move on to kind of the rehab, the bit between when you had your severe pain and your surgery, was there any, from a kind of someone who likes rehab and wants to try and get better at it, was anything that you found useful or that you were given from the physios that were useful to help you in that acute phase along with the...
Again, it was just I think when it was really, really bad, it was that sort of trying to continue to floss it. The flossing for me was the thing that always gave me the best relief. And it was sort of like, the best way to describe it is sort of like, it's an itch and it was scratching that itch. So it was giving some form of relief. It wasn't, I would say, making the situation better. I didn't know if it was actually like, it wouldn't sort of like, I'd do it and it would gradually get better over time, but it was just a way of sort of relieving some of the pain as such, which I thought was quite good. Other things, it was just, again, it was just doing different stretches, different exercises, again, trying everything that I could, because it was, if it had a chance of helping, it was worth trying to do as such.
And in terms of your confidence, you as a person, a lot of people will get despondent early on by so much pain and they're not sure whether they have faith to carry on with the rehab. Is that something Steph, you must have experienced that? I mean, patients who end up, they get to the end of up to the eyeballs with pain and they just think, why physio? We need something else. Is there any kind of rehab from your point of view that does seem to kind of help with it, apart from activity management, or is it a case of what you said earlier?
So I think some of it is the activity management. You just want to try and reduce that acute nastiness of the pain that's going on. So whether that's positions, whether they're better walking or being upright or lying down, and I think the most important thing is for them to keep as mobile and active as possible, which sounds like exactly what you did, which is great. Gone are the years where everyone used to say, oh, you take to your bed for days and days and weeks and months, and which is literally what people did. So years and years ago, my mum had an acute disc and was told that they could operate, but they didn't want to. And they said, you will spend 6 weeks up in bed. And literally, I remember I was tiny, but I remember her being literally in bed for 6 weeks solid. And you just think how much muscle loss, how much inactivity, and so, things are better in the fact that hopefully the advice people get is not to take to their beds, but to manage it by position and movement and keeping active. Try and keep your cardiac if you can going, all of those things that we, I think, slightly take for granted, but it's made. And I think as well, from a physio point of view, it is not assuming that everybody knows that.
That's kind of thing where from my come from my point of view is, from potentially physios listening, if the one or two that end up listening, if they're faced with someone who's in as much pain as Rob, you've got a lot of initial assessment tests, neurological exam to do. You've got to tick a lot of boxes. Sometimes it might be the nerves kicking in that you've missed something, or you haven't done enough, or you haven't given the right exercise. But it's okay to reassure clinicians that it's really a case of general exercise.
Yeah, and that early stuff is all about them learning how to manage their pain so that you're just not irritating it further. So, you had certain things that helped you. Brilliant. That's what you use. That might not be the same for the next person that comes in. But again, are they better off doing this or that? And whatever is best that helps their pain has got to be the best thing for them to do. And reassuring that, the majority, a lot of these patients will improve in 6 to 8 weeks. It begins to settle. Those that don't, that's when you've then got to go, okay, so at what point do you step in? And I know that's one that you wanted to discuss, but it's just that whole, when, you had 6-7 months before.
Yeah, so it would have been, April, beginning of April was when the first signs of the sciatica kicked in, and it was in June that I had this sort of, that's when it got really, really bad. That's when the fast snap was. So that would have been about 3 months in. So I'd hit that sort of 12-week window of, if it was going to go away naturally, it would have gone away naturally. And I think if it was a case of, if it was going to go away naturally, it would be getting better, not worse. So it was going in the wrong direction as such. The fact that I was doing all these exercises, and I always did have a very strong mindset of, it will get better. I need to do this. I need to be disciplined to make this better, because by God, I don't want to feel like this, for the rest of my life. But it was a case of, right, so do all this, it will get better. And when you start hearing the sort of statistics from the doctors, it's 80%, or I can't remember, but a large portion gets better in 6 to 8 weeks or something like that. And then if it's not then it'll be this little bit. And then if it's not then, it's within the next 6 months. And then if it's not then it'll be a bit longer. And only then after then is it likely to be chronic as such. So as you start getting down the line of, as time ticks on, you start to realize that this is not something that's going to go away, and it's that mindset starts to change a little bit. And I'd say probably it would have been not long after sort of starting the amitriptyline and sort of having that really sort of where I'd had to adjust the way I work and stuff like that. To avoid driving and whatnot. So I was doing a lot more work from home. It was when those lifestyle changes had started kicking in, that's when you start to get, I was feeling very depressed. It was something, because I wanted to be out running, I wanted to be doing all these.
Suddenly changed a lot.
Yeah, it's changing. And at the time, it's all we can give you, prescribe you, is either more medication, which makes you feel pretty awful, but also doing these exercises, and you start to get to a point where I'm doing all these exercises but not seeing much in the way of results, and that's when sort of you start to then speak to the doctors and start to see, right, what else is out there, and that's when, because of my situation with my work, I was entitled to private healthcare for this. So that's when I started to say to the doctors, right, can I go see a physio? Can I go see an orthopedic surgeon about this? And so they refer you, and that's when I started to sort of transition away from using the NHS and looking at what was.
So is it more a time factor for you? You got to 12 weeks and thought, okay, that I've had enough of this. It's been long enough and it's not doing what I've been told it will do if it's going to get better?
I think when I hit probably it would have been probably the 16-week mark. When I hit the 16-week mark, that's when it was a case of I can't, because it was, I think the date I'd been given with the NHS was, if this is still going on with 9 months, we'll put you in for a CT scan, an MRI to see what's going on. And then based on that, we can do further decisions about what we do. And it was this case of I'd sort of gotten to this halfway point, and it was a case of, I'm going to have to wait that long again to get, something else other than just what I'm getting at the moment. So it was that decision to sort of, right, this is falling outside the realms of normal. Let's do something about it, as such, which was that decision to go private.
Lucky you had cover. That's good.
Not too bad. So in terms of your experience, there's been a lot of qualitative research. You interview patients and they give you some insight into trends and sort of themes. So a lot of there's been a study that seems quite interesting, is one by Ryan et al. 2019. So interviewed 14 patients with similar symptoms. So they got to the point where they had 3 to 12 months of pain, just to kind of gauge themes about their experience. And so kind of I'll read it out, the kind of findings, and see if it kind of rings home. So these sorts of radicular pains are life on hold experiences. They adversely affect almost all aspects of life. Participants struggle to maintain their physical and functional independence. Their important relationships, social networks, and the roles and activities that provided joy and purpose, they weren't able to do anymore. Does that sound about right?
I would say that's very accurate. Yes. Yeah.
Okay, and then, so that's where the implication comes for us as clinicians. And I know Steph obviously is already well aware of this, but just identifying things that maybe physios could have done, asking you what was a meaningful task that you weren't able to do and help you with that, or do you think it was so sore and so painful that it affected everything?
I think it's at the time, it's very hard to sort of, when someone asks you a task that you used to be able to do that you can't do, because I was asked that, and I do recall that it was very difficult to be like, oh, I can't do that. Retrospectively looking at it, you think, oh, until you start doing stuff again, it's like, oh, I couldn't do that before. And that's when you start to realize how much, say post-surgery, it improved the situation. But going back to during the sort of period between the surgery and sort of the fast net where it was very, very bad pain, I think it was hard to pinpoint specific things at the time that I couldn't do, especially because in my mind I could still do it, but when you went to do it is when I found out I couldn't do it. And that's sort of a bit of that mentality of, I'm injured as such, but it's not going to stop me from doing stuff. But it was that period of like, I wasn't going into work. I wasn't able to drive long distances. I had to stop drinking because the medication was
the worst part. Yeah.
The worst part. But it was also like, because you weren't drinking, you weren't being as social, you didn't feel that you wanted to be social as well, because you're very drowsy and groggy from all.
Also, you can't sit. Generally, if you're going to go out, you're going to sit for a meal or sit for a drink, and actually, then it becomes more uncomfortable for you as well.
That cycle, you're in pain, you're tired, it's tiring, and then you don't want to be there. So yeah, that's
retrospectively looking at it, I think I could see all those tasks that like I used to be able to do, but I couldn't do. At the time, I probably wasn't aware or wasn't in a mindset where I would say, I can't do that. I can't do this. I can't, do all that. And therefore, it's having an impact. I'd say in terms of what a clinician could sort of prompt, I would say is one of the biggest things that I think during the whole process that no one really discussed with me was, how are you feeling about it? So the psychological aspect of this pain is, there all the time. How is that making you feel? Like, are you feeling depressed by it? Are you, comfortable with it? Is it something that you can...
And other things, and that has a big impact on your pain perception as well.
Exactly, yeah. So that's the element that I think it goes very... from my experience, it was overlooked, which when I look back again retrospectively, I sort of can't believe how sort of like depressed and sort of how demotivated I got during that period. Mm.
And, there are places people will do ODIs and various other, questionnaires they can do. Some clinicians do, some clinicians don't. Yeah. But it's actually... Okay, I get from the research point of view and having proper outcome data, they're great. But actually what he wanted was actually just someone to say, how are you actually feeling? Rather than, where's your pain? What's your pain doing? How are you acting? It's actually that, how are you?
Can you walk? Yes, I can walk, but I can't walk like I used to walk. So.
Put the assessment sheets aside and just have a chat, and then no, that's also useful information. I think that's what kind of we want to learn and get better about with. So if we go into the kind of the surgical element, if we talk about, Rob's kindly provided his MRI scans, which you will see somewhere on the screen now. We'll bring it up at some point. If Steph could ask you to talk through what you see there, and we'll walk through that with Rob. Do you understand? Or actually, if I ask Rob, do you remember what level, or remember what that in terms of?
L3, I think.
So we've got you on.
Much lower than that. I think you were 5S1.
It looked like an S1 down the bottom there. Yeah. L5 S1. There
Numbers and letters.
Yeah. There we go. Thank you. Yeah. Can tell. Obviously, I've done all the preparation before, so we're doing it as we go, but that's fine. So L5 S1.
And it was right-sided leg, wasn't it?
Yes,
right-sided. Yeah. Okay. Can you just run, before we quickly talk about surgery, can you run through where you felt your pain?
So it was...
The track.
Yeah, so it sort of started from the lower back, just above the sort of pelvis. Mm-hmm. It sort of came across, round, and then basically straight down the back of the hamstring.
Okay.
It stopped just before the knee, and sometimes it would extend a bit past the knee into the calf a little bit, but typically it was in the sort of hamstring area.
Okay. And in your foot, did you have any symptoms down in your feet at all?
No symptoms in the feet.
Okay. And no loss of power in your toes?
No.
Or your foot?
The right leg over time did become weaker. So again, post-surgery, when I started getting back into exercise, I noticed how much weaker my right leg, and especially being dominant, right-hand dominant leg, how much weaker it had become compared to the left leg. Also in its restriction and ability to maneuver. So that's something that I'm still working through now, so bring it back up to equal strength and stuff like that. But yeah, at the time it didn't stop me from sort of being able to push or do any exercise on it. But it was that sort of pain and the way it was sort of. It would depend on sort of where the leg was positioned, would be whether or not I could push off it or couldn't as such.
And do you know, or were you made aware of the fact whether you were sort of limping, or had you shifted across with your back? Were you in a slightly wonky?
So I'd shifted off the leg onto my left leg as such. So again, I wasn't. That was one of the things, is I was limping consistently with the right leg as well, which the physio also pointed out at the time, which is probably why I was getting a lot. He didn't think the calf, I was getting a lot of pain in the calf, and he thought that was more of the calf trying to compensate for the leg.
You keep the mic by your ears. They just, that's fine.
Sorry.
all the juicy stuff is kind of, as you took these mics, they operate right here. So if we turn around, then we lose it a little bit. But
do you want me to go over any of that?
Just the last bit, that'd be really.
Yeah. So as I sort of, what was I getting up to? So as I was limping on my right leg, the calf muscles were expected to take up a lot more of the strain. So I started to get a lot of pain and tightness in the calves as well on the right leg. So I was very unbalanced from a sort of, walking. Anything I did, it was always left side, not the right, which was contrary to what I would normally be, because I was right leg dominant as such.
And so that just brings briefly kind of the physio bit, is the misconception in terms of the evidence is that these radicular symptoms are segmental. So in physio, we'll look at myotomes, dermatomes, and reflexes. So Bog Duck, 2009, I can't remember, maybe I'm butchering the name, but a really good paper, which I'll link in the notes. But the definition outlines the misconception that radicular pain is segmental in origin and determines the distribution. So L45S1 radicular pain cannot be distinguished from one another, and I thought that was quite a nice link there, because technically S1 we're going to be. That's why Steph asked about the numbers in the foot, but yours was just kind of L4-3 or L4-ish potentially. So it doesn't kind of always link with the evidence. So do you? We have the discectomy. And talk to us about how you did after that. You had all the symptoms for sort of 6 months or more.
Yeah. So leading up to the surgery, again, the decision to undertake surgery wasn't one that I made lightly. It's something that when I had the MRI, so the surgeon basically talked, before I had the MRI, he talked through the possible options that were available, which was continuing physio and letting it continue naturally, going for an injection in the back, or doing a operation on it as such. And the sort of expectation leading into the CT scan is that I'd go for the middle ground. It's like, so see what's out there and then take the middle ground of having the injection. So I did have a mindset of I'll have the MRI, and then that's what the outcome will be as such.
Sure.
After the MRI, we had a catch up, and he basically said, right, injections aren't going to help you for the long term. It'll help you temporarily, but it's not going to help you long term. Okay. Your disc is too far gone. I would recommend surgery. And that decision to take surgery, I think hearing that information was relieving, because it sort of reinforced this sort of expectation that it's not going to go away with just physio now. Like, it's carrying on too long, so something else needs to be done. So it reinforced that, which was great. But then it opened up the reality, which was, right, surgery is the only way forward, and surgery is daunting. It's, for me, it was quite scary, the thought of, having a back operation, especially at, in your early 30s as well. What is the long-term consequences of that going to be? Is it going to sort of reduce my mobility for a while? So I probably spent a good 3 weeks pondering, talking to people. I talked to my GP about it as well. So it wasn't something that I went in there and it was like, yeah, I'm going to make the decision straight away. It was a case of, I went away, thought about it.
And I'm assuming
Talk
the
to
surgeon gave you some stats for what he
Yes.
expected,
Yeah.
how much to reduce your leg pain, how much.
And he was very confident. He was extremely confident. He was like, it's a very routine operation, which, you know, I believe it is. And the, you know, it's low risk and the benefits are potentially going to be quite, you know, good for you. So, yeah, after speaking with different people, GP, I made the decision. I was like, yep, I'll go ahead with it, because the alternative was living on the way I had, which, you know, you could do for another 6 months, something like that, and it won't get any better. So it was, you do it now or you don't do it. So that's when I was like, right, I'll commit to doing it as such. So there was a long build up, sort of, I think it was about a 6-week build up before the surgery, where I was going in, getting blood tests and all that stuff. So on the day of the surgery, I went in, and it was quite good. They were very nice, and we went in, and it was in the afternoon. Went in, I had the surgery. I woke up, and the best way to describe it was, I woke up and it felt like someone had hit me across the back with a crowbar. It was excruciatingly painful, but the leg pain.
I was going to say, but that was a good thing.
But the pain had gone
straight down,
and that was the thing. Is that like there was another pain, but it was different, and you knew that pain, like that pain from the surgery, that one was going to go away, and didn't matter how painful that was. It was the fact that the leg pain had gone. Literally night and day. That was it.
Yeah.
And that, do you think, in your experience, is that a common finding after surgery?
I think a lot of people literally say it's just like somebody's flicked a switch. It's just like bingo, leg pain gone. Now that's not to say some of them will have, depending on how long their symptoms have been there for, how much compression there was, because obviously you were quite lucky in the fact that, not lucky, I'm sure you maybe wouldn't necessarily think of it in that way, but you know, you had leg pain, but you didn't lose power in any of those muscles that were being, from the nerve that was being compressed. You had nasty nerve pain, but you didn't lose power. For those that have pressure for longer on the nerve, or bigger pressure that causes the function of the anywhere to be then not working. Loss of power, most of them will have some loss of reflex, but it's that power loss and how much that power loss is, and for how long, as to even when you then take the pressure off, you sometimes are still left with some of those.
The residual, and I guess
that settles generally, because again, you've been in there poking, well, not me personally, but the surgeons are in there, they're taking the pressure off the disc. Brilliant, that's all great, but there can still be some chemical irritation around that. So you've still got all the inflammation, and that takes a little while for that to fully settle.
And it was interesting because although it was, you could, I mean, even to this day, I still feel a little bit of tightness in the nerve. I wouldn't say it's pain, but it's this residual tightness, and that was very, very present sort of after the surgery, because the pain had gone away. I could feel and understand the tightness in the leg, and that was very present from sort of like day one after the surgery. So that's when sort of that whole post-surgery rehabilitation period sort of starts to kick in, and it's sort of almost relearning how to use your leg again, and sort of like bringing it back up to strength.
And did you find it hard to not go and do too much post-op? Or
were
you? I bet you were like, wow, I could just go for it.
I think the saying sort of walk before you run was very much sort of there. As soon as sort of like a couple of days after the surgery, like I just wanted to get back out and do stuff, forgetting that I've got a bunch of stitches sort of in my back. So it sort of, the sort of big differences was after the surgery, I basically almost straight away came off all the pain medication I was on a bit of Nurofen to stop with the swelling of the surgery, the wound as such. But even that wasn't that painful after a period of time. It was only very much sort of like the 24 hours after the surgery that was extremely painful. But even, the days, weeks afterwards, it healed very quickly. I was back to work. I was probably actually back to work after a week, although I was working from home, but I was then back to the office after 2 weeks. And
Sitting okay?
Sitting okay, yeah.
Driving?
Yeah, driving okay. And then, straight back into sort of what I was doing before this all started. And it was literally, that was it.
Yeah.
That's how kind of we met. I kind of earmarked you because me and Rob met through friends. We met at the pub.
Okay.
And he still had
I still had the stitches
in and the covers, and he's there with the pint, and then so that and we went for a few more afterwards, and then I texted him the next day, and it was still. I was thinking, you've been throwing some shapes, and actually it still ended up being pretty good. And I was surprised. I was a bit worried for you because it was a week or so after surgery, and you've done so well and just continued. I thought with that type of mindset, obviously there could be a kickback, I guess, a little bit because of other things, but you haven't experienced anything.
No, and I think I probably was a bit risky in terms of pushing myself too fast after the surgery. I was lucky that I didn't do anything, like didn't damage anything, didn't pop a stitch or anything like that. But as you said, it was very much like I literally got my life back, and I couldn't wait to sort of like go out there and do all the things that I realised I can do this now. I feel great because I'm not on all this medication. And that, so trying to ease back into it rather than just sort of letting yourself go. But to be honest, after about 6 weeks, I was feeling pretty normal. The stitches had come out, and then after 12 weeks post-op, not even that actually, probably about 8 weeks after post-op, I was going to the gym and starting to do running on treadmills again and stuff like that, and basically trying to rehabilitate my leg to get it back up to strength again.
Did you get any rehab between post-op and treadmill?
They gave me, so the physio again saw me a week after my surgery. Went through everything, but again she was very happy with how my progression was. That she said, here's what you do, walk, don't start running till then, and then after 12 weeks you can do whatever you want, and sort of follow this guide of not pushing it. But the last one was sort of like getting back into running as such.
Okay. And what do you remember? Just I'm coming at it from a physio point of view. We are often like objective markers, strength markers. You can start walking when you've got this strength. You can start doing running when you've got this strength. Leg strength testing or anything. Was there anything like that?
There was a standardized. So they had a standardized sort of plan and said, right, this is after post. It wasn't so much once you can sort of like stand comfortably, you can do this kind of thing. It was after 3 weeks, you should be able to do this. After 6 weeks, you can do this. After 10 weeks, 12 weeks, you can start doing that. And then after your 12 weeks, you should be back to, normal function. But in saying that, they did advise me that that sort of standard regime were for people who may not be as physically abled as what I am, because I'm, again, young, very active.
You got a good mindset about it as well.
It was that mindset of probably the other way of don't push yourself as hard.
Hold yourself back,
rather than trying to achieve the milestones, it was don't exceed them as such.
Patients like you are tricky to manage, but we prefer them the patients that we need a lot of reassurance on. Steph, in that department, do you have any go-tos? Physio receives or gets a referral for someone like Rob, who's quite healthy, has a good mindset, 2-3 weeks after post-op. Have you got any personal preferences on what you'd start someone on, or rehab-wise?
I suppose it depends how they present in the first place. So I'd want to probably just see, has he lost all of that shift? Because if you had a shift that was there for 6 months potentially with your leg being bad, and
so rectify.
So it's just making sure that is he aware of that and has it gone?
Okay.
Yeah. And then so trying to deal with the muscle shortening, tightening, working the opposite muscles, looking a lot. I do quite a lot of stuff around the pelvis, so just making sure glutes, especially on that side, that they've had the radicular pain.
What's I'm just gonna dig in there a little bit. What specifics then? What sort, if you have got any rehab sort of specific exercises?
So I suppose I go down more of a Pilates based route in the fact that I teach some Pilates as well. So, and I find that quite an easy way for people to then do that, because if they want to then continue that on, it's a really nice way for them to keep their strength.
Yep.
But I also find it relatively gentle. They can put themselves into positions that are fairly easy to be in, but still fire up the glutes.
Sure.
So I will quite often get them to do clam exercises or shoulder bridge exercise.
Yep.
Or if they're not so comfy lying, can they do some of a similar type thing, but in standing? So forward leaning, but resting. So taking their body weight off of their upper back.
Yep.
Leaning forward on a table, but then still doing some leg stuff to fire up glutes, but not letting hamstrings
hip extension stuff. Yeah.
Again, depends on age and fitness, but actually, is it better just for them to do sit to stands, but no hands? So they're just starting to use legs, glute. So it depends whether you want to go down more a pure function route of the getting you up out of a chair, getting you up there, or whether you're going right. Okay, and then depending on higher level stuff, where you want to take that, depending on what their specific sport is.
Yeah.
Or what they're wanting to get back to doing.
Okay.
But it's all about, I think, early on is trying to get them to move, because a lot of these patients, I think you were great in the fact that you clearly kept very mobile and active, but a lot of people have been so sore and so fear avoidant of moving and making it worse that they, like you said, socially and with your general life, it really stopped you doing stuff. But a lot of people literally don't move.
Yeah.
And so trying to, a lot of it is going almost back to, okay, can you walk? Have you got actually reciprocal trunk rotation? So again, I spend a lot of time with people just getting their walking back to normal. They got equal stride length, because quite often their radicular symptoms have been so bad that they haven't had that full stride length out. And every time they do that, like you say, you've still got that little bit of tightness. So again, do you shorten the other stride so at least they're equal? Or do you make them actually, okay, you're okay to start putting this through a normal movement and getting that, but there's that fear of, I can feel that tightness again. Is it going to be,
it's the fear,
is it that same radicular thing again? Or is that now? So again, it's, I suppose, some of it education for them to understand what's okay and what you would like them to be concerned about if something flares, but actually that trying to get normal mobility, normal movement.
Sure.
Yeah. The biggest thing for me, I think, was after the surgery. So about 12 weeks afterwards, I started doing yoga and Pilates, and both of those sort of slightly different in their approaches, but both of those sort of helped probably the most for rehabilitating, but also I think offering sort of further prevention of it as well, because as I'm starting to progress, I'm getting more flexible. I'm obviously working my core a lot more to sort of strengthen that, and strengthening, muscles and other exercises that I wouldn't typically do in a sort of...
if you're in the gym doing different stuff. And there's arguments for both of those. You'd need to really get your cardiac fitness, cardiovascular fitness drops into your boots, because you suddenly, especially for somebody like you, was used to running, you were used to doing, you're on your boat, you're doing low, and actually suddenly all of that stops and you're struggling to even walk around. And so actually you've got to think about, okay, can you put somebody on a static bike? Can they be in a position where they're not too flex, but actually you can hinge from your hips? So just maybe putting them on a bike and having a look at their spinal position. Does that bother them? Can they cope with it? And then just gently starting little. Don't add your resistance and your speed or time at the same thing. You want to increase one of those and just make sure. And then afterwards, especially with the radicular symptoms, it's if you're starting to add more the higher stuff, the higher level work, how much do you get any radicular type symptoms afterwards? And that whole latency with radicular stuff or nerve-based, previously nerve-based pain, is that actually they will sometimes not get it at the time, but then later they're like, oh, hang on a minute, That's all coming. So it's making sure that they just are a little bit mindful of, it's not about right now whether it's hurting you.
Yeah.
Have a little think about afterwards. Does
So
it bother it?
yeah.
When does it? How long does it bother you for? How quickly does it ease off?
And does
Just
that
so that
then
you've got an
feed
idea.
into kind of their package? You kind of give them the education, say, look, it's probably going to kick in a few hours after exercise. We want that to reduce in time. As you get more resilient, if it starts increasing, then we back off the exercise.
Yeah, I mean, I normally will say to them that actually I don't really want you having any of that leg pain coming back. So if you start feeling like that's happened, you've done too much. So really respectful of that nerve-based radicular pain that I'm sure that's the last thing you would want to have back. You know how grim it was, and actually they normally don't want that either.
No.
I think the other thing, going right back to the start, when I thought it was, something sprained or I pulled something, because I was doing these running sort of like, I'd just gotten back into running throughout the New Forest. I think that mindset of, it'll be better if I push through it, and I kept pushing myself, probably compounded and made the situation worse very early doors, because it was exactly what I shouldn't have been doing, even though at the time I thought, I was helping it by just sort of pushing through it. It was, my body was saying, no, you need to not necessarily rest, but basically stop what you're doing.
Okay.
Yeah, absolutely.
And do you think you've therefore learned in the how to sort of almost listen a little bit more to your body and what it now tells you, not just with this, but in general? Do you think it's made you a bit more?
It's definitely it changed my mindset about, rather than just pushing yourself and sort of like, because when you're younger, you've got like this whole mindset of sort of, if there's a barrier, you can just literally like push through it, force through it as such. It's changed it, and I don't know if it's because of, again, growing up, getting older, that your body's giving you some aches and pains. Don't push it. You don't need to go out and sort of like prove yourself or anything like that. Just sort of take it back a notch and sort of gear it up where it's comfortable, not where you're sort of overexerting yourself.
Yeah. No, absolutely. Final kind of rehab bits from advice from Steph. In terms of return to running, is it a try it out and see how you go, or do you have anything where you want someone achieving certain plank outcomes or leg strength outcomes, or is there anything there that a physio can advise?
I mean, from a leg strength point of view, as long as there's no obvious weakness, some people can run with leg weakness or foot weakness.
Sure.
I've seen patients that don't get their full power back and they can manage. It's harder work, but it's not to say that they can't do that. I suppose so. Ideally, yes, you would love them to have their full power back. A lot of it, again, is then going to be about, so walking, is their gait pattern normal? What are they doing with that? Because if you're then going to be running, you're then taking that gait pattern just through a faster speed. And then looking again as well at pelvis control. So again, can they single leg stand? Can they single leg squat? Can they do that?
Nice.
Can they do that? Can they stand on the edge of a step, drop down, back up with one foot without losing that control around their pelvis?
Yeah.
How much can they then manage from a point of view of looking at their back muscle strength? So we know that without a doubt, those that have had either ongoing back pain or back surgery, that quite often the surgeons, when they'll look at the MRIs, will see that actually the muscles in their spines have become much more fatty. So they don't have so much good muscle mass. Okay. And again, it's about getting that back. Because I think there's been a lot of this, everyone's got to have great core, you've got to do the abs. But actually a lot of it is also about returning their spinal strength. Okay. So, glutes, pelvis, great. But you've then got to think about adding up that upper, sort of middle upper back strength and isometric holds.
And how would you train into that? How would you?
So early doors, I will get people on their hands and knees, just doing little knee hovers, so that they're just getting core to work, but they're beginning to work shoulders. Keeps their back in a really nice neutral position.
Yep.
But so it doesn't necessarily irritate anything. They're not on any nerve type pressure stretch either, so it takes them into a position of relative ease.
Yep.
You can then add lifting for longer, holding for longer, And then if you want to move the arms out, you can get them going out to more of a plank or a mini type plank.
Yep.
So on elbows, so shorter lever,
Okay.
but actually still working abs, and that works the backs as well.
Mm-hmm.
And then bringing in resistance bands. And I think for a lot of patients there, and you may not have felt this, but a lot of patients are more wary of adding rotational type movements.
I think that's, even though I'm still kind of developing skill set, otherwise there tends to be rotation where someone calls their name and they twist or they have to bend to.
And also I think when they're first, often their injury is I was bending and twisting, and so that whole going back through that.
Yeah.
But actually rotation is a big part of our normal movement.
Sure.
We don't really work like
It is
thunderbirds. You know, we have to add rotation in everything we do. There's some form of rotation. So trying to bring some of that back in, whether that's with TheraBands, whether that's with small, you don't need to do heavy weights, and early on we don't want to add more extra weight, but just using body weight movements to do that as well.
Yeah, that's great. I think that's identifying all these areas that we can kind of have a couple of things working for the patient so that we can iron that out. In terms of the kind of breathing control, I know there's a trend now in sort of sports or kind of MSK rehab where we're focusing on the trunk and the breathing control, the diaphragm. Do you do any of that work, or do you think that plays a role in
I think there's
low back
definitely a
patients?
role for it. I mean, I think again, because I do some of mine from a Pilates background with that, then the breathing is introduced with that early on. And sorry, just flipping back, I suddenly realised I haven't answered the bit you said about returning to running.
Okay. That's fine.
The only bit I didn't add is, so a lot of people, if you've got access, and there are a lot more gyms that now have those, are the anti-gravity treadmill machines that I have with other patients when they've been they're desperate to run, but they weren't sure they were ready to.
Okay.
So putting them into one of those and running them at maybe 80, 90% of their body weight and just seeing how they feel and what happens to any of their symptoms.
Sure.
And then slowly increasing that back up so they can get used to actually looking at their running, their patterning,
Give them feedback.
then see how that feels, and then increasing their body weight after they've done that a couple of times to just see how they feel.
And that also, I think for me, not post surgery, but when I was sort of suffering with the pain, one thing I'd love to do is go swimming, because again, it took the weight off. It would just sort of find its natural where it felt comfortable, and you could sort of like just pot around the pool, and it was active, but it was nice as such.
And again, from a hydro point of view, post-op is great because of exactly those same reasons. But also you can then start adding extra things on you to add more resistance against the water.
Sure.
Swimming's great in itself, but actually you can also do some running on the spot in the water, bit deep in the water, so you're just trying to keep yourself upright. And actually, that's brilliant hard
so
work.
you give you give the patient outcomes to start it here, get your sternum, get your belly button, and then you're progressing. So quite a nice one. So Rob, you back to everything. You don't have any limitations.
No.
No.
I think the only residual sort of niggle I have is I've still got the slight disbalance in terms of flexibility. Strength-wise, I think they're back to parity, the two legs, but flexibility-wise, especially because I'm doing my Pilates, I'm doing my yoga, when you do it on one side, you notice that the left side's a lot more flexible than the right side still, and I think that's just something that will work itself out over time. Sure. It's not something that would happen in a month or something. It will take, several months for it to sort itself out. But other than that, everything's back to the way it was before, sort of the song.
Right.
And Steph, in terms of a discharge that you'd be happy to sign off on, sounds pretty ideal from a physio's point of view. Is there anything that you would want to finally assess? I mean, we want to focus on the patient, but is there any outcomes or anything you want to do to finish the assessment, and then any final bits of advice that you'd give to a patient as you discharge them?
So I suppose final bits of advice I would think about, okay, how much are you now doing from a rehab point of view? Because obviously initially everyone's not desperate, but they're keen to maybe be doing the things that you're being given to do. Yep. As you feel better, obviously the want is that I don't need to do any of that again. So it depends again on how they present, but if they can do a plank, if they can do some single leg stuff, if their pelvis looks like they're stable, if their gait is more even, if they're back to doing some of their cardio, if all of that is great, then we're good. But it's then making sure, okay, well, what else do you still need to be doing some of what you have done?
The maintenance work.
To just tick along.
Okay.
So you're already doing other stuff yourself, which is, as I say, in a way, it's quite nice. Some of our physio stuff can be linked into then doing class type based stuff.
Good sales pitch, isn't it? You know, I don't know what came first. I normally say to patients, I don't know who stole from what, but we use a lot of Pilates or they use from us. So that's not something.
But again, you can modify all of that into different things. But it's just thinking about, okay, so if you're back in the gym, do you want to think about just add in a couple of those things that you think were useful? And some of them, it's quite often the exercise that they hated doing that was the harder one to do from a mental point of view as to how they were controlling it, what they were doing. But actually, can you give them a couple of ones that they can do, quick, easy, functional stuff? So I quite often give them a couple of things to do just in standing that they can do, but just keeps them just, again, a bit aware of have they got symmetry? Do they feel like they're using both sides equally? Can they check that every now and again and go, actually, I'm having to really use my brain power on that side, whereas my other side is all good. So not just the physical, but actually that whole, what's your effort level? Are you having to really think about still using your right side, or does that feel as easy to fire it up as the left side? So a couple of things to just say, okay, keep doing something a little bit, but you don't have to be doing it quite so regimented. If your symptoms start coming back or you feel like you've got weaker, then maybe you've just dropped off doing some of those, and do you want to just bring them back in a little bit until you're feeling okay? And then I think the other thing is for you to learn to manage if you get another acute back attack, not necessarily your radicular symptoms, but as soon before you had this episode, you would have had the odd episode of back pain.
Yeah.
You would have dealt with it.
It was something that, if I'd been out in the garden shoveling a load of soil, I'd get a stiff back. And it'd be like, oh, yeah.
But if you now were to go and garden and got a stiff back, or it felt, your brain might do a little bit more of a, okay, hang on.
Exactly.
May not, but it may do. And
will.
again, that's a conversation I will have with people. And you'll sometimes, in your process of your rehab, you may have a bit of a blip where things flared up again. And I always will say to patients, actually, it's no bad thing in the fact that now you learn that this is just, you've had a bit of a blip, but you have to learn to manage that, as you will have to as you go through the next 10, 20, 30 years. So actually learning, okay, what do I do if I have a slight flare post-op, however long that is down the road post-op? But, what do you need to be thinking about doing? You got to keep it mobile. Do you need to heat it up? Do you need to ice it? So just teaching you to think about how to manage it if you have.
I guess sometimes it's a bit of a blessing in disguise if a patient does a bit too much while still under your care, because you have the opportunity to plug in that education and say, look, this is going to happen when you discharge you, and actually this is how we deal with it. I guess some people probably have that without. And then that's where they end up happening. So in terms of the threat value, you've had a pretty big threat to the system, and that's where I think Steph's asking about, like, have you changed your overall approach to things, because the body perceives it as a threat. But if you've mentally got on with it and you're happy with where it is, that feeds into the kind of outcomes as well.
And it's like I think before sort of all this, I would have a different approach to tasks than I do now. So, like, just giving an example, out in the garden, if I was to do a load of gardening and move a lot of soil, I would say, no problem. Couple of days, just solid work, chucking it and then moving it about, not a problem. Now I'd probably say, that's something I don't want to go down, because I know if I do that, I'm going to hurt, and it's going to hurt. And just the thought of that then leading into being a trigger for something reoccurring isn't something I want to risk anymore. So you minimize it, or then use, say, mechanical aids to change how that task is approached. But I think when you've lived through something like this, it does have a life-changing approach as to your body, I think, will naturally want to do everything in its power to prevent it from happening again. It's not so much sort of becoming reclusive and not doing anything. It knows, like, I know that not being physical will make the problem like that. That's a recipe for the problem coming up again. So it's keeping active, but also keeping, like, being exploring more variety. So not just doing strength work, but doing also like all your different yoga, Pilates, that sort of like branching out as such.
Yeah.
But I think we're almost done there. I think we've, unless there's any other topics you fancy talking about.
No, and I think again, you know, from what you were saying about you wanted to be asked how you felt, but I think as well post-op, it's that just checking in.
Yeah.
How you doing? How
Absolutely.
is it what you expected?
Yeah.
Because I think we can sometimes fail to understand their expectations as opposed to we know what generally happens post-op with majority.
It's a big
of
surgery,
patients,
isn't it? I guess.
But
as well,
for them, it's the first time they've had that. You know, how many have we seen patients go through that? A lot.
Yeah.
But for you, it's the only time, and actually, it's just making sure that you know you listen to and you make that a very bespoke package for you, rather than right. This is what we do at this time. We do this at this time. We do this. You've got to be really reactive to what he presents with and how it then responds, and then how you tweak it and take it.
Yeah, no, that's interesting. I think clinicians listening will hopefully take a bit from it. You take a lot from this, you know, the guidelines and the advice. In terms of to finish up on how you fit into the evidence, which is really interesting. Yeah. So Wilson et al. 2016, all right, their predictors of a positive post-op outcome was that you had more severe leg pain, a better mental health status afterward, before, shorter symptom duration, and a younger age. So you probably fit into that, apart from the shorter symptom duration, which was 6 months, which is pretty hard going. And so in terms of the indications for surgery, I appreciate that, you know, everybody's different. But just in terms of a reference point, so the International Society for Advanced Spine Surgery came up with some clinical indications, which probably can be debated, but their interpretation was patients with signs and symptoms associated with disc herniation, confirmed with imaging, and a failure to improve after only 6 weeks of care would probably qualify for surgery. Yeah. So you again, you kind of an anomaly in that you push for 6 months, which is great. But
I think that's one of the, and again, one of the things that I'd say, looking back at this, the biggest sort of, I'd say the one thing that I'd sort of, if I could give sort of feedback to sort of like the whole process that I've gone to like clinicians, is I think once you've hit that threshold of say 6 weeks, 12 weeks, where it's starting to become a bit more abnormal, that's when it needs to trigger the imaging.
Absolutely.
The whole idea of we're not going to take a MRI for another 12 weeks or another sort of like several months down the line. I think getting that image done early doors, if it's starting to become abnormal, gives you insight as to how severe the issue is. It then gives you the insight whether or not to continue what you're doing or going and doing something a bit different.
Empowers you a bit, doesn't it?
Yeah.
All right. Well, thank you both so much. I really appreciate it coming on. Hopefully you've taken some away, and we've taken a lot from you, Steph. Thank you for coming.
No problem.
So that's a wrap for us here. We'll hopefully do some more content coming soon. Thank you very much.
Thank you.
Cheers.